Hi, Cole Beeler here, talking about our upcoming respiratory viral season for 2018-2019. So to me, getting ready for respiratory viral season is like getting ready to try and hold back a sneeze. You know what's coming because the southern hemisphere gets theirs first, and you try to prepare as much as you can to fend off the damage, but then it hits, and it's like one of those sneezing paroxysm that goes on forever, and eventually you've had so many sneezes that the people who are going to say God bless you, they give up, and then you're stuck cleaning up all the snot and boogers while trying to look cool. 2017-2018 was a bad year for the flu, the highest severity actually since 2003, with a peak of 7.5% of all visits to primary care or the emergency department. And this lasted forever and was responsible for 10% of all deaths during the interval. That's like a huge red wedding. And there were 181 pediatric deaths with 710,000 estimated hospital admissions over the season. That said, the vaccine actually did relatively well, definitely better than I expected, with a 40% efficacy, which is about pretty average for a flu vaccine. I don't think it will be as bad this year. Australia only had a fraction of the cases compared to their previous season. The vaccine has been adjusted to cover H3N2 better, which is the main circulating virus last year. Vaccine efficacy was great last year for the H1N1 variant, and it should continue to be. And the live inhaled vaccine is an option for patients that do not like needles. But I guess I don't really 100% know what's going to happen, and I could for sure be wrong. But even if flu isn't as bad, we are still at risk for having a lot of disease related to the other respiratory viruses. If a patient comes in with a pulmonary syndrome like a pneumonia or a fever, I'd add back the RVP PCR to your diagnostic workup and would note that the rapid flu test misses a lot of diagnoses. The sensitivity of the RVP PCR as well correlates to the depth of the sample that you're getting. You really want to get all the way back in the nasopharynx. And Dana says if the patient isn't crying a little by the time you're done, you haven't gone far enough. If you're worried about bacterial co-infection, use procalcitonins to help decide if antibiotics are necessary. Because antibiotics just don't kill viruses. I'm sorry, bad news. Protecting your other patients will be huge this year, so get ready to put on yellow gowns, gloves, and masks again. Isolation for respiratory viruses requires droplet and contact for everything except for flu and coronavirus, which only require droplet. Patients will need to stay in isolation for 7 days or until they are symptom-free, whichever is longer. If a patient has flu and is in the ICU or is immunocompromised, they need to stay in droplet until they prove they are negative with a repeat RVP PCR in order to prevent transmission in these patients who could be prolonged shedders. And don't forget to take care of yourselves as well. You want to build a protective wall between yourself and the wildling invaders. Hand hygiene, adherence to isolation requirements, and getting your flu shot, preferably soon, will help protect you and your loved ones. Leave your masks on until you are at the door ready to leave the room, and stay home if you're sick in order to protect your patients and your colleagues. Thanks for watching. Email, Twitter.